about to move on to our last presentation of the day, which will be Dr. Christine Whitmore, who comes to us from a local urogynecology practice. So urinary symptoms in women with ALD are something that we've heard a lot about from our patients and our family members, and we wanted to find someone who could helpfully paint that picture a little bit better for us and tell us what options are available for managing those symptoms. So here is Dr. Whitmore.
Good afternoon. Last talk. All right, we're going to talk about the bladder and bowel and ALD and a lot of what we don't know. No disclosures. X-linked, as you know, gene mutation. There's several phenotypes, and females have been labeled in a good and maybe bad way as being carriers. Now, in terms of the bladder, demyelination can disrupt the major functions of the bladder, involving both storage, filling, and emptying. Bladder control is complex, and it requires a lot of coordination between the cerebral cortex, front brain, back brain, pontine area, and sacral micturition. So obviously, lesions within the nervous system can affect bladder function. Most commonly, the bladder becomes overactive, something called Detrusor hyperactivity, and we get reflexive emptying, means the bladder just kind of goes when it wants to without any sensation or warning. There's urgency to urinate, frequent urination, including nocturia, getting up at night to go to the bathroom, and often urgency urinary incontinence, gotta go. The sphincter can also be highly overactive, which is the outlet to the bladder. So the bladder can't empty. So commonly when we study patients with ALD, although personally have not studied many, we have something called detrusor sphincter dyssynergy, which is when the bladder or detrusor and the sphincter both contract at the same time. Guess what? There's a backup, the pressure in the bladder is elevated, and this can result in backup of urine or reflux into the kidneys and kidney disease, as you're well aware. After long-standing problems, you can actually get bladder flaccidity, where it doesn't contract at all. Then you have retention of urine, overflow incontinence, which is just like overflowing a dam, a little bit of leakage here and there. And of course, incomplete bladder emptying. So if we look at the bladder, no pointer, okay. If you then look at the bladder, you can see that the brain is involved, the upper spinal cord, and the lower spinal cord. The bladder itself is the bubble, the outlet is where the sphincter is. And so there's 3 different nervous systems that regulate the bladder and its outlet, or the sphincter. So during the filling and storage phase, basically parasympathetics are inhibited, sympathetics are stimulated, and the voluntary nervous system at the sphincter is also inhibited. Then when it's time to urinate or void, it's the opposite occurs. The stimulation of the parasympathetics, inhibition of the sympathetics, and inhibition of the somatic nerve, so the bladder can empty to completion. That's in a normal person. So some of the studies have compared ALD to multiple sclerosis because of the lesions in the nervous system and the similarities in the signs and the symptoms with regard to the bladder and the bowel. So what we want to do is preserve renal function, maintain continence, which is important for social abilities, and minimize urinary tract infections. So approaching management then, we need to categorize the bladder dysfunction, because you can actually have more than one. Failure to store urine from the overactive bladder, detrusor overactivity, resulting in frequency, urgency, nocturia, and urgency urinary incontinence, or failure to empty the bladder. Then we have the detrusor sphincter dysnergia. They're both competing. Bladder contracts, sphincter contracts at the same time. So you have an inefficient bladder contraction, and the other category, late stages, is bladder hypoactivity, where the bladder can't contract at all. And you have retention, interrupted urination, and increase in frequency. But you can have a combination of all of those, and stress urinary incontinence, especially in women, is very, very common. So there can be a concomitant urgency urinary incontinence and stress, both of which need to be dealt with. Okay, in the blue boxes, we can see if we compare all of the studies or meta-analysis of ALD and voiding dysfunction, we can see that frequency and incontinence are the most common. In Detrusor overactivity or Detrusor hyperactivity is much more prevalent than the Detrusor sphincter dysnergia. So there's a breakdown then in the myelin sheath surrounding the nerve cells, and this affects in the brain, which affects through the micturition center or voiding center, affects the lower urinary tract symptoms and therefore the quality of life. So 14 patients, and mind you, none of these studies are large. They're just not there yet. Doesn't mean they won't be. One way to study voiding function is to do validated questionnaires. One of the most simple things to do that you can all do is a voiding diary. How much you drink and what time, how much you pee and what time, how severe was the urge, 0 to 5, how much leakage do you have, and you can see the different episodes through the day, and was it mild, moderate, or severe. So one little survey over a 2 to 3 day period can tell us a lot about where you are in this whole spectrum of symptoms. And there are other validated questionnaires as well, which help us to measure the quality of life, how much it affects your daily activities of daily living. So here's another study, and this was nice because it showed that 100% of men and 86% of women had overactive bladder symptoms, so we know it's very common. But when it comes to the bowel, only 20% of males and 10% of females. But what we have to understand here is that a lot of this stuff is underreported. Patients don't tell, providers don't ask. And that's how it is with a lot of rare conditions. So we know that it's common and it affects quality of life. So now we talked about this Detrusor sphincter dysnergia. Okay, so the way we diagnose that is something called urodynamics. That's like an EKG of the bladder. You put a small infant-sized catheter in the bladder and one in the vagina or rectum, and you study the bladder as it fills and as it empties. And you can learn a lot of information because it measures pressures. So the Detrusor sphincter dyssynergy, well, you can actually demonstrate the bladder contracting at the same time the sphincter is contracting. So you'll have an increase in the amount of urine left in the bladder. You can see involuntary bladder activity and an increased bladder pressure. An increased bladder pressure is important because if it gets to be over something 40 centimeters of water, for example, then you start to get backup of urine and potential kidney disease. So it's important to recognize where each patient is in terms of their own disease progress. Now, if they do have DSD, we can give something called an alpha blocker, which will help the sphincter relax and improve bladder emptying. But some patients go on to intermittent catheterization because the bladder just doesn't work. So overactive bladder in general has some predisposing factors, environmentally, in women, vaginal delivery, postmenopausal, prior pelvic surgery, any myopathy, neuropathy, obesity, underlying bowel dysfunction, and a lower socioeconomic status. Also, genetically, there's a racial predisposition for Hispanics and Europeans, and a mutation has been found in type 1 collagen activity. So, overactive bladder then. Normally, as we said, the detrusor fills with urine, it gets full, the urethra relaxes, and one urinates. In an overactive bladder, however, the bladder tries to empty itself before it's full. Therefore, you get frequency, urgency, nocturia, and then incontinence. So if we classify it then, we have frequent small voids on our voiding diary. You may get up several times at night to urinate, which definitely affects quality of life because then you're tired the following day. And if this happens every night, it really can be detrimental to good health. And you can be in the bathroom line all the time, looking for a bathroom. You have a constant urge to go to the bathroom. This can be very distracting from your social relationships, family obligations, and at work. So we know that the incidence of overactive bladder is very prevalent. 16% of men, 17% of women. We have patients on medication, and we'll see a slide about that. Not everybody stays on their medications, and the ALD population may have some special concerns because a lot of the medicines do cross the blood-brain barrier, so a lower dose and close observation by your healthcare provider will be very important. And there's poor compliance because of the side effects, and therefore low patient satisfaction, and they rarely result in complete symptom resolution. So you can see that overactive bladder is more common than diabetes, asthma, breast cancer, so it's pretty popular. So our guidelines then mandate that we do a good history, find out what your symptoms are. We do a good physical examination, see what all the signs are, and at least look at the urine. If the urinalysis is abnormal, we send it for a culture to rule out infection. We check a post-void residual if you have any symptoms of incomplete bladder emptying. That's where you put a little ultrasound machine or a scanner over the bladder after you've urinated, and we see how much is left. And we mentioned the bladder diary questionnaires, and we can also assess for the number of pads or diapers that people are using per day. A National Association for Continence is a patient advocate organization who did a survey for overactive bladder and found that it alters behavior in social situations. Patients commonly cancel plans, and you refrain from normal and intense physical activity, so it's hard to stay in shape. And they found that there was a frustration from living from the symptoms in 80%, and that's what brought them to the doctor or healthcare provider. 40% were embarrassed, and almost 40% had a fair amount of physical discomfort. During the physical examination, it's not just a bladder, it's not just a bowel. It sits in the pelvic floor, which sits in a body. So we have to kind of look at the pelvic floor muscle integrity. That's the ability to contract and isolate the muscles as well as relax them at will. In women, we look for signs of menopause, atrophy, also prolapse, which is drop of the organs often associated with childbirth, which is concomitant in many patients. We do a neurologic exam, a bladder cough test to rule out stress incontinence, and check the urethra itself. So the first line of treatment for bladder problems, overactive bladder, is lifestyle modifications. And the second line is medications, and there's basically two kinds, anticholinergic or muscarinics and beta-adrenergics. But lifestyle modification is first line and should be attempted in everyone. So during our physical examination, we look at the muscle structure as a clock, and you have big muscles at the upper pelvis, and you have something called the levator ani, which is from 3 to 6 on both sides, and these control the urinary and bowel sphincter, which is very important to get an assessment of their strength and their ability to relax, because when the overactive bladder, the bladder's overactive, the muscles sometimes go into spasm by a special response called the guarding reflex. So the deep layer of the pelvic floor, these are the levator ani. The pelvic floor muscles are like a bowl, and they surround the urethra, and they surround the bowel sphincter. And then you also have some very shallow muscles that also surround these structures and can help in completing urination and completing defecation or making a bowel movement. So the internal exam, probably more commonly than not, in an ALD population or an overactive bladder population, the muscles are in spasm. So a 0 would be no pressure with the exam, and a 4 would be severe pain when palpating the pelvic floor muscles. So lifestyle modification. If you're overweight, losing weight has definitely been shown to improve urinary incontinence. Dietary changes can be very important and practiced by everybody. Alcohol, caffeine, tomato products, carbonated beverages, these are bladder irritants. And if you do them excessively, even somebody without an overactive bladder can urinate more frequently. So just by moderating the amount of intake of these simple things can make you a lot better. And 40% of Americans are constipated. So treating constipation can also be very helpful. And on that note, increasing your fluid intake, increasing your fiber content. If you have some irritable bowel symptoms, going gluten-free, dairy-free, these are all things that can be very, very helpful, because if you relieve the constipation, you relieve the bulk of organs that are distended in the pelvis. So therefore, there's more room to pee and poop, so to speak. You must learn to do pelvic floor muscle exercises, commonly known as Kegel exercises. Only 50% of people can isolate these muscles. As a healthcare provider, when we do our exam, male or female, you can have the patient contract right around the digit. And you can tell whether or not the patient how strong the contraction is, whether it can be sustained, and whether there's relaxation. So if you're going to do these at home, a physical therapist will probably instruct you to do 8 to 12 contractions, holding each one for 10 seconds, and then doing this 3 times a day. Just don't tell the police officer when you ran the yellow light that's what you're doing. They won't get it. And most important is pelvic floor physical therapy. Since not everybody can do this on their own, physical therapy is very, very important. And it's important to the ALD community in general to keep moving, keep things strong, keep them flexible, and we add a little biofeedback of the pelvic floor for those who cannot identify the muscles properly. All right, so home exercises, not just going to the physical therapist once or twice a week, that doesn't cut it. The stuff your physical therapist will have you do at home. And those things will include stretching, strengthening, things to stabilize your body, keep things in the posture proper. And some patients who have high-toned muscles can actually learn how to do an internal massage of the muscles, which is part of the therapy. All to empower the patient. I guess my energy transfer is, well, we have a dead battery. It's not going to be, can somebody, there we go. Okay, so what we want to do then is we want to normalize the pelvic resting tone, and you can see the muscles here, the big muscles on the top. And remember, they're connected to your back muscles, they're connected to your leg muscles, and then you have the inner pelvic muscles, which are all connected too. So part of the physical therapy is working on your gait in general. Many patients will walk with their head forward and like this a little bit, especially if they have pain with it. And physical therapy can really help to straighten that out a little bit. So we normalize the pelvic floor contractile abilities. We get a normal range of motion in the spine as much as possible and in the hips. And hopefully we can even restore sexual function. Sometimes in patients who have spastic muscles, for women we can use dilators to get the patient ready for sexual activity if they have pain with sex, something called dyspareunia. And we want to be able to return to some sort of recreational exercise. Okay. Must be some energy coming out of my hands today. Okay, now, not everybody has tight muscles. Some people have really weak muscles. You know, because some of the muscles and of the condition that the ALD community has, they can't really contract and isolate the muscles. So 0 would be no response, and 5 would be a strong contraction where you can grip against a probe or a digit and actually lift the pelvis off the ground. Okay, so with biofeedback, as we said, not everybody can isolate their muscles really well. So we want to increase the awareness of the pelvic floor, and this can be done in one of two ways with the biofeedback machine. You can put a patch on the skin outside of where the urethra and bowel exit the body, or you can put a probe in the vagina or rectum, and the patient is then told to contract, and you'll see the blip over there is a contraction, and they're able to relax all the way. And they can also then be shown visually if they're contracting the wrong muscles. So hopefully get the proper coordination going. All right, so we mentioned the second line treatments, the drugs. And as mentioned, a lot of these drugs do cross the blood-brain barrier, so one has to be very careful about taking them, but they can also cause retention of urine, dry mouth, constipation, blurred vision, and a decrease in memory or cognitive function, and they take 4 to 12 weeks to take effect. A new medication also promotes calming the bladder down, but it can elevate the blood pressure, so one has to be monitored carefully. All right, so what medicines? All right, as we mentioned about the blood-brain barrier, there is one called trospium on the end. That one is a quaternary amine, which means it's different than the other ones, which are tertiary. The tertiary ones cross the blood-brain barrier. Trospium does not. So that might be a drug for anyone who has involvement of the central nervous system. And then we mentioned the new one, mirabegron, again, we have to watch out for the potential side effects: glaucoma, tachyarrhythmias, increased heart rate, myasthenia gravis patients should not take them, or people who have gastric retention when they can't empty the stomach. And then patients who have uncontrolled or severe high blood pressure should not take our newer drug, mirabegron. And we can see the whole thing with the drugs. They're not perfect. You can see that almost 80% of patients stop taking their drugs, and very few restart them again. So this has been studied, the cognition that have validated tools. Even in cognitively normal older adults, sometimes you can get a change in the brain metabolism with these drugs. So providers should counsel patients on the associated risk, prescribe the lowest effective dose, and consider alternative treatments or additional treatments. So everything is a risk-benefit ratio. I mean, it's a risk to take the drug, but the benefit can be dry, or getting up one time instead of 5 at night. So it's all risk-benefit ratio. The important thing is to have a good relationship with the person who's prescribing your medications, whether it be your primary care neurologist or urologist. So what happens if the first two lines of therapy don't work? Well, then we go on to something called neuromodulation. And one thing that most people can do is something called percutaneous tibial nerve stimulation. An acupuncture-sized needle is placed at the ankle on the middle side, and the session will last 30 minutes of electrical stimulation. You're stimulating the posterior tibial nerve. It's done weekly for 12 weeks and is FDA approved. The only problem, of course, with it is that you got to go in every week. But it's non-invasive, it's safe, and you can get some mild cramping, which is rare, in the leg or the foot, but it does require the weekly trips. It is office-based. Sacral neuromodulation, and I'll put a disclaimer right up front, in its current stage, you cannot get MRIs with it. However, within a year or two, you will be able to. So it will be a good, perhaps, treatment for patients with ALD. And what sacral neuromodulation is, you get mild electrical stimulation of the sacral nerves, and they control the pelvic floor muscles, the lower urinary tract, the anal sphincters, and the colon. So it works on the nerves that supply bladder and bowel function, so it is a neuromodulation as opposed to our medicines which work at the level of the bladder muscle. And there's an implanted generator, that's the actual size of it. It's not big. It's done in stages, so you can have a trial first to see if it's going to work. And if it's going to work, you pass the stage 1, which means your symptoms are 50% or great better, then you can go on and have the battery implanted. In its current stage, it gets changed about once every 5 years. However, there are 2 new competitors coming out. It's always nice to have competition, and they will be MRI safe. And the batteries will be rechargeable and last for 10 to 15 years. And this is where it is. It's basically on the back, in the sacrum, and the battery is implanted just under the belt line and just under the skin. The electrode itself does not go into the central nervous system. It tickles, so to speak, or stimulates the nerve roots and not the central nervous system. So you can get pain at the implant site. Lead migration happens in about 7 or 8%. It's usually associated with a slip on the ice or a fall. You can have infection, which is very rare these days. And there can be technical device problems and even undesired stimulation. But these happen in about 5% of patients. So as implants go, it's relatively safe and will be available to this population in the near future. So have obviously well-controlled studies, which basically show that there's 76% improvement with using the Sacral Neuromodulation device compared to 49% response in standard medicines. So long-term at 5 years, you still get a 3 times greater improvement quality of life, and 45% of patients are completely dry. Now notice it doesn't promise a 100% cure, it says more than a 50% response, which for most people is pretty good. Because if you're getting up 8 or 10 times at night to urinate, you're much happier if you're getting up once or twice. If you're wearing 5 pads a day, it's much nicer to wear 1 or 2 and go from a diaper to a panty liner. Okay, so this is a study with 23 patients who had bladder and bowel problems, secondary to spinal cord injury. So this is the neurogenic population. And in that population, there was still about a 70% response rate. So it should be considered in patients with neurologic issues. Finally, botulinum toxin, which can be used in patients who have neurogenic overactive bladders. And Botox A is the most potent neurotoxin known to mankind, and it works very effectively and is approved by the FDA to be injected into the bladder for a refractory, meaning difficult to treat overactive bladder. There is a risk, however, of urinary retention, so if you already have trouble emptying your bladder, you're not really a candidate. And in women, there's an increased incidence of recurrent urinary tract infection. This is how it's done. A telescope is placed in the bladder, and a little needle injects the bladder in about 20 different areas. And the results are known in 2 days to 2 weeks. They last 3 to 6 to 9 months. The disadvantage, of course, is you have to have it repeated. Oh, okay. So then, in summary, Detrusor overactive bladder, overactivity, overactive bladder, we want to suppress the urge. And then if you get really good when you go to biofeedback or with your physical therapist, they can teach you a quick flick maneuver, which is when you have the urge to go, you sit down and you do 5 to 10 quick contractions of the pelvic floor muscles. And sometimes it's enough to turn out the urge to urinate because it inhibits the reflex. So we want to ensure bladder emptying, so you should at least once have a bladder scan to see how much urine is left in your bladder after you urinate. We have anticholinergic medications, and we mentioned again that trospium, the one on the end, is a little different than the others, may be safer. Botox, you may have to do intermittent catheterization afterwards because you could go into retention in about 9% of cases. The sacral neuromodulation will be MRI friendly in the very near future, and anybody can do percutaneous tibial nerve stimulation, which is covered by almost all insurance companies. Detrusor sphincter dysnergia, we want to consider alpha agonists, which are safe in the neurogenic population, as it relaxes the sphincter and allows you to empty better. In some people, we'll learn clean intermittent catheterization, which is catheterizing every 4 to 6 hours as needed. You do need good use of your hands to do it, though. So we always want to discuss options with the patient, tailor therapy based on symptoms and their severity, which should be followed up by questionnaires or avoiding diarrhea, and realize that it may take multiple or multimodal therapy to make you better. Okay, thank you very much. I'm open to questions.